Dr. Smita Vishvarupa, who is a yoga therapist, VYASA, will be presenting yoga therapy for breast cancer patients. The result of research examined the effects of yoga in specific psychological parameters in women with breast cancer undergoing radiotherapy will be presented. VYASA Bangalore research will be briefly presented, and research at MD Anderson will be elaborated.
Namaste everybody. Welcome to this presentation on breast cancer. And firstly, I would like to acknowledge VYASA Bangalore, Dr. Nagaratna, Dr. Nagendra, Dr. Shravi, Dr. Mara and team, as well as Dr. Lorenzo Cohen and his team from MD Anderson for giving me an opportunity to present their work here today. A little bit of background about the research with breast cancer. As cancer is becoming one of the major killers around the world, in many countries, many leading countries, VYASA Bangalore did a lot of homework back, and the first randomized trials were published in the 90s and early 2000s, and I would like to just briefly run through a couple of studies. One of the studies is Dr. Raghuvendra's study, and the other is Dr. Banerjee's. And the effects of an iterated yoga program in with the genotoxic stress in breast cancer women who are undergoing radiation. This was one of the first. And you can see here in this, the slide here, this is, instead of having too many slides, I tried to have just a couple of slides for both the studies. So hats pre and post, this is the questionnaire on hospital anxiety and depression scores that we have. So you can see in the white, these columns are the yoga columns, and this is the control, so the pre and post. So consistently in all the post data that you see, you can see yoga group had least anxiety or depression score compared to the control group, as well as the perceived stress score. The pre and the post yoga group has definitely a very good low score compared to the control group. We also could see some of the DNA damage with pre and post, and with the radiation treatment that breast cancer patients went through, the yoga group that went through the program intervention had least DNA damage than the control group that participated in the study. This is one of the studies. The next is effects of integrated approach of yoga therapy, the program that VYASA designs on nausea and emesis in breast cancer patients. And the study design, we had about 174 patients screened, and 98 were randomized to yoga or to control. And this study had a special, a unique follow-up, which was pre-surgery, post-surgery, pre-radiation, post-radiation, or pre-chemotherapy as well as post-chemotherapy. And you have the other dropouts from the yoga as well as the control group cited. And what is interesting in this was the significant differences between the yoga and the control groups. The very significant things that you can really make out is the post-chemo-induced nausea frequency, which is these scores in the control and the yoga group, which significantly says that yoga has a great impact, or yoga has a role to play in the not just only the quality of life and others, even in maintaining the symptoms which cancer patients has. And these symptoms for cancer patients means a lot. When they go through this treatment, it is not a simple symptom to go through, but this in fact indirectly or indirectly influences the treatment options itself. So these are a couple of studies that I thought I'll just run through. And because of these studies which were done at Bangalore, MD Anderson, Dr. Lorenzo Cohen, who is the director, took an initiative to do some of the studies at MD Anderson. And first couple of studies that were done at MD Anderson were the copies or the mirror of the studies that were happened in Bangalore. So there was a collaboration between MD Anderson and VYASA Bangalore, and we had randomized control trials for women undergoing radiation, and phase 1, 2 to 3. The phase 1 and 2 has been completed, and the phase 3 trial, or the biggest trial that we are doing, is in progress right now. So the phase 1 trial, yoga intervention group attended 2 yoga sessions per week for over 6 weeks. Each class was facilitated by a certified yoga teacher from VYASA. and waitlist had standard of care. So whatever the treatment standard was at the hospital with the social groups and other things that happened, which was common for both the groups. It was just the standard of care for the waitlist. So the yoga program included breathing and loosening practices, what we call Sukshma Vyayama, and postures, 7 simple asanas, deep relaxation, that is the DRT practice, alternate nostril breathing, the Nadi Shuddhi Pranayama, meditation. This was the program which was used for the intervention. And the assessments were made, the baseline, that was before they could get into the program, the baseline assessments were done, taking their parameters, and they had 6 weeks of treatment, the 2 sessions for 6 weeks, and then the assessment was done 1 week post-radiation, and the next assessment was 1 month post-radiation, and the next one was 3 months. So basically this was 3 months follow-up, and also the control groups were also assessed at the same corresponding times. So the patients approached were 137. We could finally randomize about 71 patients, 30 to yoga and 31 to the control. And again, the follow-ups as I just mentioned. And some of the couple of slides that I will present to see what are the improvements that we could find is the general health well-being. So the general health for the yoga group, of course, was higher, but we could see that at T2, the general health for the yoga group had a real high impact than the control group, and also physical functioning both improved post-treatment. This is the post-treatment that you're seeing here. So post-treatment, both groups improved at the physical functioning, but yoga group had a real high score at this point at the physical functioning. So change from the baseline, this is again SF36, a questionnaire that we assess to see the physical functioning and general health and well-being. So at this, the yoga group had all the improvements, which is above, but the control group had a lot of negative improvement, or you can say the deterioration that you could see. It's not even above the baseline for this. And in this study, again, another interesting thing that we could assess, or we tried to assess, is the benefit finding and impact of the event itself. So when the cancer patients go through this, it's not just the parameters you assess, but it is a big experience for themselves to see how this actually impacted their life. So in this you can see the impact of event, the benefit finding. Of course, yoga group had a higher benefit finding than the control group because of the the practice and the impact. And the impact of event, and here this score that you see is actually the intrusive thoughts. So you could see the T1, that is 1 month follow-up, yoga group had increased in intrusive thoughts than the control group. And when we were discussing and assessing why is it so that why the control group was having less intrusive thoughts than the yoga group, we could see from the trauma data that is available that for any person to understand or to adjust to the traumatic experience that they go through in their life, intrusive thoughts were more helpful, and we are associating, or we are trying to think that the association between this is directly related to the benefit finding, that at 1 month follow-up patients had more intrusive thoughts, were also having more benefit finding from the whole experience itself. So these are some of the comments from the patients, not from one, but many patients who participated in the study who were highly appreciative of the study. And after this phase, what was next? So after the first trial was done, we could move on to a better design because we had good experience from the first phase trial that we did. So in this, the improved or the changes that we could make is we have just a waitlist control in this, and as just now Dr. Selvan was presenting, that you do get commented that it's placebo or it's not exactly the the intervention that is causing the effects. So we did add a component which was stretching. So here we got into 3 groups. One is yoga, one is control, and one is active control, which is stretching. So this group did meet with the instructor for the same amount of the time that yoga people met with, and they did some stretching practices which were very beneficial for breast cancer patients who were undergoing that phase in treatment. So the number was 150 instead of 6 to 1, and 3 groups. Instead of 3 months follow-up, we moved on to 6 months, and classes, instead of 2 weeks per class, we could do a design to 3 weeks, 3 classes in a week. And for this, the funding was provided by another thing that we were just talking about, that the funding, we were funded by NIH for this and our 21 grant. And again, this was a collaboration between MD Anderson and VYASA. Inclusion criteria, breast cancer stage 0 to 3, stage 1, stage 2, stage 3 cancers. Patients were included, 18 years of age or older, who could read and speak English, no major psychiatric diagnosis or bone metastasis in their disease, and patients who had taken yoga sessions in the previous year actively, if they were active yoga practitioners, they were not included in the study, but otherwise patients with active or non-channelized deep vein thrombosis is another exclusion criteria that we had for this study. Assessment times, you could see this is almost the similar assessment design that we have, but instead of 3 months, we had another assessment point. It is at the 6 months, which is an extended assessment, and the waitlist controls were assessed at the correspondence, exactly at the corresponding times with the yoga patients. And the yoga program, breathing and joint loosening exercises, the Sukshma Vyayama, as we had in the first one. Postures, these were some of the postures that were, these were the exact postures that we used, and alternative nostril breathing and meditation. And outcomes assessed, subjective measures, health status and physical functioning, SF36, sleep, fatigue, benefit findings, spirituality, depression, objective measures were cortisol rhythmicity. Again, this cortisol rhythmicity is something that the Bangalore people had done, and this was again included even in this study at MD Anderson. So 178 patients randomized into 3 groups, yoga 53, 56, and 54, and the consecutive follow-up points that we see. Patient characteristics across all the 3 groups, that is yoga, stretching, as well as the waitlist that we had. We had similar patient characteristics with their age, race, education, and staging, etc. So, one of the outcomes that we have measured is fatigue, and because we had included an active group, which is stretching, we did expect that active group, which the exercises that the active group did were some of the exercises which were assigned for the breast cancer patients at that stage. So we did expect some of the good changes, even in the control group when they were participating in the study, and with no doubt, here the most group which benefited was the control group, and yoga group did almost close to the stretching group, a little better. When we did the follow-up, it was a little better, but this was with the fatigue. SF36, physical functioning. From here on, that was the only area in the fatigue that yoga people did not do really well or did not do as well as the stretching. But in all the other findings that we have, yoga group has really done well than the other. So this is from the end of treatment, so this is not the baseline, from the end of treatment up to 6-month follow-up. So the stretching people were of course, were doing better than the yoga, than the waitlist, but yoga group did really, really well. And you can see the differences that between the yoga and the control group, yoga and the stretching here. So in general health overall, wherein the stretching as well as the control were at some points below the baseline, but yoga group did fairly well even here with a high levels at the 1 month and 3 month follow-up, and a slight deterioration that you start seeing at the 6-month follow-up, and this could be basically because of the practice that patients might not have kept up. Benefit finding, even here, the group of stretching and the waitlist, you can see that went below the baseline level after their 1 month follow-up. As soon as they start their treatment at the hospital and the follow-up 1 month follow-up, it was below the baseline, but yoga could retain it constantly almost at the same level that they were at compared to the other 2 groups. cortisol. So this is again cortisol within cities. Again, cortisol is a stress hormone, and a couple of things that usually people measure is the amount of cortisol secretion itself, as well as the cortisol slope, which you can find here. And this is a baseline slide where you can see the most blunt slope here. You can see is the yoga slope. And the blunt it is, it's not good. The more steepy or the more curvy the slope is, the better it is. So at the baseline, yoga had actually most blunt. But as you go and see here, by the end of treatment, yoga has the most steepest slope, which signifies that due to the radiation, the damage that can happen with the cortisol rhythmicity is prevented or is better with the yoga group than the other two groups that you could see. And even at the 1 month follow-up, you can see this is even better. The steepest, the curve is deeper with the yoga group than the other two groups, you can see. Another important thing is people learn the intervention, participate in the intervention for about a month or 6 weeks while they go through their treatment at the radiation. But once they complete the radiation or once they complete their hospital stay, they also stop doing it. So another thing that we interestingly wanted to follow up is the attendance and their PCS's physical change score between. So these dark lines that you see is the red ones are yoga, and the dark ones are the people who attended their classes, who had highest number of classes. And these dashed lines are the people who had least number of yoga classes, even though they had opportunity to have it. So the least number of yoga classes people had is almost as equal to highest attending stretch group. So yoga, even though people say that the stretching or the exercise component is major, it's not just some exercise, but it has definitely a higher difference with the normal stretching and stretch exercises that people would do. So these were phase 1 and phase 2. So right now, what's going on? From the R21 granted 150 patient study that we have, right now we have a phase 3, or one of the biggest study, which is again funded by NIH. And this was non-blinded, and another component that you can see here, this is single-blinded, meaning when patients are approached to this study, we do not say this is a yoga study, this is said this is a relaxation study, we would like you to give you some relaxation because you're undergoing the stressful experience of cancer. Only after the participants are randomized, the yoga people would know that they are in a yoga group. The other people still think that this is just a relaxation practice. So this is a single blind, and stretching and relaxation. So in the previous, you saw that the component was just stretching, the control people did just stretching practices, but here for this design, even the component of relaxation, which is guided imagery, or just lying down and letting the patients rest for 5 to 10 minutes. So the component of relaxation is again included here to see how the original designs or relaxation practices, the scriptural practices of yoga differ from just lying down or resting. So 600 participants, and instead of 6 months follow-up here, we have a 1-year follow-up, and again the design is we do have a second randomization that we do, and one of the, say, 100 patients come out of yoga group. In that, again, 50 patients could get into maintenance arm, in which the instructor calls the patient every month and sees how their practice is going on. So basically, you're motivating the patients to keep up their practice for next 1 year. So 1-year follow-up is done. Also, one of the important measures that we're trying to see is the economic outcomes, in which how, especially in a country like America, how yoga can be taken to insurance peoples or somebody so that it can also be covered under the insurance plan to make it more into the standard of care. Some of the patient comments from the second study. And these are definitely different patients, but even though we see a substantial amount of data that we analyze and publicize, it means more to the patients and their experience and their participation in the study. These are some of the patient comments which I probably should be sharing. Thank you.
So we just and then come back to
in terms of your trial with the stages 0 to 3, what do you put to classify different stages? This is a big range. And how do you assess, the stage 3 patients and different people? And how are you going to improve
because we have radiologists and other people who are involved, and the screening is something that we do. But despite of that, we are now able to fit in the big range of patients into classes and assessments. But I think we would try to, we would get that feel once we go to, because this is a new study and we have started just last year. By the end of 1 year's follow-up or so, we might feel that, difficulties of, stage 3 follow-ups with those patients and things like that.
In fact, regarding the stretching control, sorry, one more question. We did discuss about our trial. The problem is, since we have the first trial, we want to show the proof of principle the yoga people get into very well. Maybe next trial we will include the stretching or other regular activities permanently. That's a very good point. In fact, we did touch on that.
in terms of one is the staging, so in terms of the type of breast cancer, you said it is for that, like like there is metastasis, so it's all
Receptive, non-receptive.
okay. Any other questions?
I had a quick question. So it seemed like there were a few dropouts from the study. Like, what kind of drop-off do you expect as you do it? And then are you going to do an intention to treat analysis at the end, or?
We do, and I think some of the dropouts that we see right now is people who, like at MD Anderson, the research that we carry on, we have a lot of patients who come from out of state for the treatment, because MD Anderson is one of the reputed cancer centers, and the patients from out of state is, one of the difficulties to follow them up, because, of the distance, or to come all the way from a different state just for a, appointment and things like that. And I think it could be various reasons, and definitely we will